Welcome, everybody. Good morning, good afternoon. We will get started in just a minute, just allowing people to come in, but we are excited to have you here. If you could please put your name, where you're coming from in the chat. It'd be great to see where you all are coming from. All right, I think we could get started. Welcome, hello. My name is Megan Urkel, and I just want to welcome you all to the celebration of SDOH Innovation presented by the SDOH Academy faculty. This is the first session of our webinar series, and we will be discussing and talking about a celebration of SDOH innovation. Next slide, please. Like I said, my name is Megan Urkel. I am a senior project manager at Health Outreach Partners, and I will be facilitating today. Next slide. Today's agenda, briefly, just really some introductions, housekeeping, level setting of what is social determinants of health and who we are as an academy. We'll be talking about SDOH innovation opportunities and reflections. We have a very special guest speaker today, Dr. Guy Fish, and we will close up with some Q&A. A brief housekeeping. So as you notice coming in, you are muted. So hopefully, please keep yourself muted to prevent background noises. If you have any questions throughout the session, you can pop them into the chat, and one of our hosts or panelists, faculty members can answer that in real time. And we also have a Q&A window if you would like to ask a question at the end. This session will last about 60 minutes and it will be recorded. The recordings and the slide will be shared at the SDOHacademy.com in a few business days. And if there are any issues with technical assistance, please message any NCMLP team member via the chat. Next slide. Just want to acknowledge that this project is supported by HRSA. Next slide. I also just want to give a shout out for my other co-facilitators today, Bethany Hamilton and Eureka de la Cruz, who I will be introducing in a few moments. So who is the SDOH Academy? Just briefly, the Social Determinants of Health Academy is a HRSA-funded work group of National Training and Technical Assistant Partners, or NTAPs, and we work together to develop training and technical assistance opportunities to help staff from health centers, health center controlled networks, and primary care associations develop, implement, and sustain SDOH interventions in their clinics and communities. For more information on what we do, please visit this link, the SDOHacademy.com. Next slide. We are a collection of many NTAPs, as you see here. For more information on individual NTAPs, you can also click on the link for more information. Next slide. And so before we get started into SDOH innovation, I just want to take a step back and talk about what are social determinants of health. One of Healthy People 2030's 5 overarching goals is specifically related to social determinants of health, which are to create social, physical, and economic environments that promote attaining the full potential for health and well-being for all. Social determinants of health, or SDOH, are conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. SDOH are grouped into 5 domains, as you can see in the image here. So the 5 domains: education, access, and quality, healthcare access and quality, neighborhood and built environments, social and community contexts, and economic stability. So social determinants of health have a major impact on people's health, well-being, and quality of life. They also contribute to wide health disparities and inequities. For example, people who don't have access to grocery stores with healthy foods are less likely to have good nutrition. And here listed are just some examples of social determinants of health, including safe housing, transportation, racism, discrimination and violence, polluted air and water, as well as language and literacy skills. Next slide. So what is SDOH innovation? So innovation is a new solution to an unmet need that has the ability to transform services, processes, and systems to accelerate impact, as well as address SDOH factors to improve the health of their community. Health centers and primary care associations have really been at the forefront of designing and implementing and scaling innovations that contribute to the unique needs of their communities. They develop and scale life-saving and life-improving innovations that really harness the impact that the community health centers serve. And on that note, I would love to hand it off to my colleague, Bethany Hamilton, who will talk to us a little bit more about the SDOH Academy.
Thanks so much, Megan, and welcome everyone. It's so good to see how many different disciplines and backgrounds are represented, and the geography is widespread in the chat. So thanks so much for joining all of us on SDOH Academy today. Some of the resources that we've worked over the years to develop for you, especially during the pandemic, were really created to help you not just build your competency in addressing the social determinants of health, but also innovate. These things were done with the pandemic in mind and ensuring that you would have access to these resources. So let's go to the next slide. Back in 2021, and it's still accessible, and we encourage you to access these materials on our SDOH Academy website, was a breakthrough series. We in the training and technical assistance world provide a lot of webinars and recordings and resources like publications. And we realize on SDOH Academy that you probably need one space to better understand what are all of these resources about. So we helped to create a webinar series to capture these different resources and materials and training topics into 4 categories. And then we walk through those categories to help you break through all of the different resources and clutter that's out there and access the materials that were essential to building your capacity to really address the social determinants of health and social drivers for the communities that you serve. Let's go to the next slide. Then we reached preparations for 2022. And just like many of you, we felt that, oh my goodness, not another webinar. So what did we do? We decided we were going to gamify the experience. We were going to add an element of competition to really help inspire your participation and inspire innovations. We also wanted to ultimately recognize those of you who were able to continue plugging away at serving individuals in your communities during the pandemic. And so we created the Social Determinants of Health Academy SDOH Innovation Showcase Competition. We're so happy to see the levels of engagement that we saw throughout a webinar, an online module series, and then finally a showcase event to highlight the winners and all of those who submitted to the showcase competition. So we invite everyone to please visit the different topics as they were addressed through the webinar and modules. They're all accessible, and everyone in health centers and your partners can continue to build competency in a more fun and measurable way through the materials we created in the 2022 Innovation Showcase Competition. By the way, we have been asked, are we going to bring this back? Cross fingers. Yes, we'll be able to bring it back in just a couple of years through our TTA work. Let's go to the next slide. And so just highlighting once again some of those winners, we wanted to recognize first and foremost, once again, KKV Comprehensive Family Services out in Hawaii for their winning SDOH innovation that was showcased earlier in 2022. Then we also wanted to recognize Aloha Care. Many of you may ask, well, this is a lot of Hawaii. Don't you wish we could all go out to Hawaii? So we brought Hawaii to you. No, but the Promise of Hope was an amazing innovation that was submitted and also recognized. And then finally, at Northwestern University Feinberg School of Medicine, their Center for Health Equity Transformation submitted an innovation called Reimagining Patient Navigation. You can see the different categories that folks submitted innovations in, and you're also able to use the hyperlinks or visit the SDOH Academy Showcase Innovations Competition website to learn more about each of those innovations and the others that were submitted. Let's go to the next slide. And finally, we're here in 2023. We pulled all of these resources together, including this webinar series, and we'll add the webinar series to our 2023 resource compendium. That's where we summarize and highlight the 2021 resources, the 2022 innovation showcase resources, and then we'll continue to add resources that we've collected in 2023. Again, this is really about making training and technical assistance materials available and accessible to you so that you can continue to innovate, continue to inspire others by sharing your work. Let's move on. And I will now pass it on to our colleague on SDOH Academy, Eureka de la Cruz from NAC. Eureka, all yours.
Hi, thank you, everyone, and it's great to see you all. Thanks for joining us today. So I'm going to talk a little bit about how this all aligns with the different efforts from HRSA. So HRSA knows very well that you all are doing some very innovative work in your health centers and in your communities. And so these are just some of the opportunities to tap into the resources and efforts at HRSA in terms of technical assistance. So HRSA has a quality improvement fund, and this really, the goal of this fund is really to activate and to really recognize all the innovation that's happening at health centers, but to really catalog that and elevate those stories to the field in general. So really take a look at that, that resource there. And then there's prize challenges. And this is here, this is something that is to recognize all the great work that you're doing and to, provide some funding to support your efforts at the health centers, but more so test these efforts on a smaller scale. So really trying to get that seed funding to get started with some of your innovations. And then finally, we have all of us here on this call, the NTAPs that are here that are part of the SDOH Academy. We're really here to help all of you, again, to think about the innovations that you're working on. Either you're currently working on them or you're looking to get started. But also we have our primary care associations and our health center controlled networks. And there's just a lot of great resources for all of you out there in the field. So one of the things that we wanted to present to all of you and just kind of just help with thinking about today's presentation. And this is a great resource from the planning committee that put today's webinar together. They found these questions from the American Hospital Association, and we wanted to really share these questions with you all just to think about them and to reflect on the content that will be shared. So really think about how can health centers and community partners best advance and sustain efforts to address SDOH for their patients? How are we using technology to better identify and respond to the SDOH risk factors that we see in our communities? And then finally, how can we use our limited resources to significantly move the needle towards change in our communities? So these are just some reflection questions for all of you to consider as you hear today's presentation. And now it's my honor to introduce you all to Dr. Guy Fish. He is currently the CEO and president of the Greater Lawrence Family Health Center. Heard him speak back in August at CHI in Chicago, and then recently last month in DC. So it was great to hear from him. He talked a little bit about the Health Equity Impact Compact that he's a part of in Massachusetts. So he'll be telling more details about that today. But just to provide you all with a bit of background of Dr. Fish, he is committed to equitable improvement in the health of communities through innovation. In 2021, Dr. Fish became the CEO of the Greater Lawrence Family Health Center, an FQHC serving over 65,000 patients in Lawrence, Massachusetts. The health center has a residency program that also graduates leaders in community-based integrated care. Dr. Fish's career spans multiple subsectors from direct patient care to Wall Street. He sits on the boards of several healthcare startup companies focused on innovations in healthcare. Dr. Fish was the acting CEO of Next Phase Therapeutics and Selenix Diagnostics. He was a leader at Fletcher Spat Incorporated, a healthcare strategy consulting firm, as well as Fletcher Spat Ventures, which is its healthcare investment vehicle. He's also currently as the chairman of the board of the Alterum Institute and the treasurer of the Harvard Alumni Association. Dr. Fish has been very active in social justice and anti-racism. Dr. Fish is also a trustee of Beth Israel Deaconess Medical Center and chairman of the Medical Education Committee. With a BA from Harvard and his medical doctorate degree from Yale, Dr. Fish has practiced internal medicine in Delaware before earning his MBA at Yale University. And Dr. Fish is also a co-author on different patents as well as publications. And somehow in his spare time, he finds time to run, and he's actually run the Boston Marathon twice. So with all of that, I will go ahead and pass it over to Dr. Fish. Thank you for joining us today.
Eureka, thank you so much for inviting me. I want to thank you as well as Bethany, Megan, Ariel, and Maya for having me present some of my recent goings-on in the realm of health equity. So thank you, and good morning or good afternoon, everyone, depending on where you are. I'd like to spend some time speaking with you about a development here in Massachusetts called the Health Equity Compact. And it started with a few friends of mine that I got to know very quickly once I became the CEO and president of the Greater Lawrence Family Health Center in Lawrence, Massachusetts. Lawrence is a community that is majority minority. I believe we're like 85% Latinx, most of that being Dominican, some being Puerto Rican. But it has a long history in being an immigrant city. And way back in the 1840s, when the textile mills were established here, and immigrant labor was required to get product to market, and wasn't treated very well. And so it was the home of the Bread and Roses labor strike in 1902, a pretty famous one. And ever since then, it's really been an economic struggle. And as economics, as Megan was saying, are a significant part of the three things that go into how are we constructed in our society to have equal and equitable foundation for everyone, socially, physically, and economically. So these three things come to the forefront, and they've been in the forefront at Lawrence for a very long time. But in speaking about the Health Equity Compact, it starts in our shared experience of the COVID pandemic, and those of us wanting to take some bold actions towards the things that we were seeing. So next slide, please. There we go. Thank you. The purpose of the Health Equity Compact is, as you see there, it's because of the outsized impact of COVID on Black and Brown communities that a number of leaders in the health care landscape in Massachusetts got together and said, we've got to do something about this. And we knew at the moment the confluence of, the Black Lives Matter, George Floyd activism plus COVID and the disparities that were happening there created a moment in which we had the nation's and the world's attention on health equities in particular. So the time is now, and we set about to really get some transformational and breakthrough changes in the health system now. So in a moment, please don't move the slide yet, but in a moment, I'll show you a slide that is supposed to be a wow chart, and it is for me every time I see it. But when we began thinking about who we needed at the table to represent the communities, Black and Brown communities, we began to look around Massachusetts and realize that another moment had happened, a moment where there were just an astonishing number of Latino, Latina, and Black leaders at healthcare institutions throughout Massachusetts. And we started calling and collecting these individuals, and it started with, a list of 30 some odd, and then it grew to 50, and now we're at 67. So if you go to the next slide, please, we have, there you are. That's my wow moment, right? I mean, it's, if you click one more time there, that's me in the middle. I don't know why I'm in the middle, but taking attention off of me and clicking once more, you'll see three people who really were instrumental in getting this off the ground. And right next to me, Jeff Sanchez is a Latino who was one of the first 3 or 4 in our state legislature as an elected representative. Now he's been there a long time, and he's one of 35 or 37 that are in the legislature. He's gone on to a lobbyist career, but he knows the ins and outs of how do you get things to happen in state legislatures. To the far right, towards the bottom, Michael Curry is past president of the NAACP in Massachusetts, but current president of the Massachusetts League of Community Health Centers, some 52 organizations that are either community health centers or lookalikes, and we all band together for representation on Beacon Hill, as we call our state house. So he's been leading the charge, organizing, and then to the far left, Juan Fernando Lopera is the chief diversity, equity, and inclusion officer at one of our large, just globally recognized health centers here, Beth Israel Lahey Health. And so the three of them have been really leading the charge. I've been happy to do my part, but you can see how this has fleshed out to so many other people, Blue Cross Blue Shield, universities, top people at Brigham and Women's Hospital, who was actually Bob Higgins, who was a classmate of mine at Yale Medical School. I mean, just the types of institutions and the sheer number has just been astonishing. If we can move to the next slide, we've had to go to a second slide to add the newest members. At the top right, I had the pleasure yesterday at a health equity meeting of meeting Dr. Monica Burrell, who is a past executive director in the Health and Human Services here in Massachusetts, and Craig Andrade below her, who's a dean at the BU School of Public Health, and many others who are now joining this. And as you can see, it's broadening from Black and Brown to also Asian members who are facing similar issues of health equity in some of the various and many different communities that they have. It's not a monolith by any means. So moving to the next slide, this has come together in a movement to advance health equity as policy. And that's really, really, really an important concept here. All of us are doing our darndest, doing our best as individual health centers and institutions. But, when we talk about social determinants of health, or to update that, societal drivers of health, what society are we talking about, and how does society work? Well, we've agreed that as a society, we will air our needs and grievances through a representative democracy and a political process. And so if you want policies to change, because policies are the ecosystem in which we all operate, and if the ecosystem is not healthy or helpful, then we have to change it. And so that was the beauty of having Jeff Sanchez saying, we can do this. We can take the moment and the collective presence and advance an agenda of health equity. And the more that we talk about this, the more people begin to realize health equity, that's never been on the table before. Here in Massachusetts, we have something called a Health Policy Council, HPC. The Health Policy Council had no minority representation on it. They're setting policy for all of us on healthcare, and there's no minority representation speaking to our truths as to how healthcare was being delivered and received in the Commonwealth. So we are privileged to have the Senator Payano, who's up here in the Lawrence area, Liz Miranda, Senator Miranda, and Representatives Garcia and Bud Williams. Bud, it goes back a long, long time in central Massachusetts. He's very, very seasoned in advancing health, in advancing policy, moving what is now our House bill and Senate bills 2257 and 799 through the legislature to advance health equity. And what is in that bill, you may ask? Let's go to the next slide. The principles are, the priorities here are 6. We want to create the policies that embed health equity in everything that we do in a sustainable way. We know we need to have representation in governance, like that health policy council that I mentioned. We need measurement and accountability. Workforce is an issue for all of us, and health equity is inextricably linked to the issue of workforce. We'll talk more about that in a minute. Healthcare payment and delivery reform, which is separate from coverage and access. You need both. You need to have access to healthcare, but you also need, once you have access, to make sure that it's being delivered in a way that is equitable and that the payments are facilitating that. And last but not least, by any stretch of the imagination, really, really focusing on social determinants of health. We'll rephrase that as societal drivers of health. So moving on to the next slide. Putting 6 things in front of government elected representatives is always challenging. So we boiled it down to 3. And the 3 are really looking at systemic policy changes that changes the ecosystem by prioritizing equity in state government, by standardizing and reporting on data for health equity, and then improving access to quality and care. And I'll speak to each one of those on the next several slides. So next slide, please. So as I mentioned before, who knew? Sometimes, you don't really detect the water you swim in or the air that you're in until you actually begin to examine it. And there was no one accountable for health equity in the Commonwealth. Even the Health Policy Commission had no representation. So we're changing that by advocating for the creation of a cabinet-level executive office of equity to be led by a secretary of equity, and health equity would fall under that. We, as I mentioned, need to diversify gender and racial and ethnic composition within the leadership of key state agencies, not just this division or bureau, but everyone needs to have gender, racial, and ethnic diversity as part of how they operate. And then investing in community-defined and led efforts to build healthier communities. And again, this is such an important change in how we think about governance, not being, elected representatives being those who need to collectively come up with the good ideas and legislate down to the people, but the people bubbling up their ideas in individual communities, because you know best what's happening in your neighborhoods and your communities and what you need, which may be different than literally half a mile down the road. So let's do that. Moving to the next slide, talking about the reporting and data. It's an adage I've been on a long walkabout between my days as a practicing internal medicine physician in rural Delaware to my coming back to healthcare delivery here in Lawrence, Massachusetts. And in that long walkabout, lots of things that Eureka was kind enough to mention. One thing stands out as a mantra in the business world: you manage what you measure, right? And if you're not measuring it, good luck in managing it. So we have to measure things about how health equity is being received, improved, or the opposite. And that has to be across provider and payer organizations. We need to have accountability mechanisms in for reporting that data. And then direct state agencies to really not report that data, but also respond on it, to identify disparities and to respond on those societal drivers of health. And then to get to the last one, which is the improving access and quality of health. Next slide. Here, it's very easy sometimes to focus on the constraints that we live in the American healthcare system, being an employer-based insurance system. So your coverage is linked to your employment. If you're not employed, you need government aid or assistance. You're on Medicaid, you're on Medicare. We in Massachusetts have been proud to be leading the charge on what we call full coverage for everyone, including the original Obamacare, which was called Romney Care back in the day. But we also have to take it further and look at people who may be immigrants. What's their status? And young people and others who, are recently released from incarceration. So we have to get full mass health coverage for everyone. We have to address the burdens of medications that are needed for people who have chronic conditions. Some of these medications are getting quite expensive, the specialty drugs, with respect to the pricing of those, and particularly hard hit in communities of color and low income communities. The reimbursement for telehealth services, thank God for telehealth, right? I mean, it was really our saving grace during the pandemic, particularly when exposure to people who had essential worker jobs was, there was no other way for them to get the healthcare that they needed other than telehealth in many instances. So we need to continue that because we see how important it is for many communities, urban and rural, right? But moving beyond coverage opportunities, there's also the workforce issue, really defining what is a career ladder for entry-level workers. If we took a poll of just the 350 of you who were on this call and asked, in your role in healthcare, have you been having challenges in your workforce, particularly at the lower pay echelons, retaining people who are making rational economic decisions to go from an $18 an hour job to a $20 an hour job at Chick-fil-A or Home Depot, right? That $2 an hour more times 2,000 hours, that's real money. That's $4,000 more for someone who's bringing home only $35,000, $36,000 a year to begin with. So, we need to have in place opportunities for entry-level people to see their path forward to higher paying positions should they choose to go there. And then we also need to think about how can we really address in our provider organizations the standards that we want to maintain, but a lot that would also allow for us to bring into the workforce, for example, people who have been trained outside the US and who have met the quality standards. But because of the way that we've structured the health system here, are somewhat excluded from participation in healthcare delivery, particularly if they bring with them language skills that we need in these communities. In Lawrence, 70% of families here speak a language other than English at their dinner table. We need to bring healthcare to them in languages that people are comfortable hearing, good news or bad news, and making them part of the team for healthcare improvement because we are speaking literally their language. So if we can go on to the next slide, I want to drill down on this particular area of improving the quality of care. We've spoken already about societal drivers of health, and to the slide that Megan showed, which was a circle outlining, now we have a person, but it's the same message, which is that the things that we think about in terms of tongue depressors and stethoscopes happens 20% of the time in the delivery of healthfulness. We don't spend our lives in the hospital or in the doctor's offices. 80% of our lives or more is spent outside of those settings. And so, there are those in society who, believe the Horatio Alger's myth that we all, need to pull ourselves up our own bootstraps and not be dependent. And that whatever befalls us is our own fault and problem. They would probably argue that, these health behaviors in the orange, that 30%, that's on you for smoking or not drinking or not losing weight or whatever. But none of us are immune to these conditions. We all have things that we do and maybe want to change, but that shouldn't be the limiter to whether or not we have help available to us when we need it. It shouldn't be what dictates health equity and outcomes in health. In fact, fully 50% of what dictates and drives our health are things like our physical environment or education, job status, family support, income, community safety. So let's really open the curtains all the way and take a look at all of this and figure out how do we address the 50% that's at the top, physical environment and social economic factors as well. So moving on to addressing these social drivers of health, societal drivers of health, if you move to the next slide, please. The Health Equity Compact, in its improve access and quality of care section of the legislation, has specific language in there, which we hope will break new ground. And we are actually beginning to get around the country and talk to other places. I know that Michael Curry, whom I mentioned earlier, as one of the 3 principals of this initiative, is either going to or just came back from Missouri to speak about this because they're interested in figuring out a way to get policy in place to drive societal drivers in the right direction and get to better outcomes. One of the things that we're borrowing actually from Rhode Island is the whole idea of regionalized equity infrastructure. Again, being specific to the needs of a particular region, getting cross-sectoral partnerships, whether it's healthcare plus transportation plus education plus affordable housing, and getting them all around the table to figure out how do we solve this problem. Establishing and funding communities of opportunity, or otherwise called health equity zones. Again, Rhode Island is ahead of us on this. I see in the chat room Bethany saying, yes, community-centered care. Absolutely. That's exactly what this is. But it also requires getting braided funding streams to create shared ownership. The little bit of money I get from a health center, grants and other things is great, and I can put it towards this. But if you're getting money as affordable housing and we got someone else with transportation and we're all solving a core problem, we get much further, right? Creating a health equity zone trust fund, which is beyond the funding streams, but also, raising money and getting government grants to say, this zone, there's a trust fund established for it. Go after it, go get the work done. And an advisory board, which again is filled by people from the community who can keep track of and hold us accountable for addressing the needs of specific health equity zones as we develop and create them. So winding up, only 2 more slides. Next slide, please. So what are we doing now? We've created this legislation. We're engaging with our stakeholders on one side and our policymakers on the other side to get broad support for this act to advance health equity. And the way that we're doing it is we're going back out to the communities and having community engagement forums. And we have, web coffee, Zoom coffee with people in a series. We had our first ever Health Equity Trends Summit. And the next one I'm particularly proud about because, again, Eureka mentioned my being chairman of the board of Altarum Institute, which is a quasi think tank, quasi government contractor. But the Altarum Institute did a report for the Kellogg Foundation several years ago. And I can't remember if it was pre or post George Floyd's murder, but the title of the report was The Economic Cost of Racial Injustice. And they came up with a very, very large number in the trillions of dollars lost due to racial injustice. And as we were going about this work, I recommended to the Health Equity Compact, Altarum, to turn the next page and do a specific report on the economic cost of health inequities. And so that is being financed by Blue Cross Blue Shield Foundation of Massachusetts. And we are looking to kick that work off and get a report out later this year. And then finally, public opinion poll to demonstrate support for this. So these are the current activities that we're doing to advance an agenda of health equity as an innovative way of really pulling together, how does our society work? It works through political processes and engagement. And this is our effort to do that. So the final slide shows you a poster for the next event that we're having up here in Lawrence, Massachusetts on May 3rd at our senior center, which we call the center because it's much more than senior. And, that's going to be on May 3rd. We're holding a discussion. We're airing Oprah Winfrey's film, The Color of Care. But more importantly, in the middle, we have, if you want more information on this effort with the Health Equity Compact, Lindsay Tucker is leading the charge at the Mass League of Community Health Centers, who are, representing 52 of us, passionate about this work and the Health Equity Compact, which is way beyond these 52 health centers to the 60 some odd senior leadership CEOs, presidents of Massachusetts institutions that are Black and Brown and now Asian. And then Angel Bourgeon is with a consulting firm, JSI, that's helping us do the work as well. And I think she pulled together these slides. And of course, if you're not anyone these days, if you don't have a QR code, so there's our QR code, you can take a picture of that with your phone and drive directly to this link about the event. And then from there to the Health Equity Compact, which you can see the logo in the upper left-hand corner there. So thank you for your time and attention. I think I'll close out here. And I think we have some time for some questions.
Thank you so much, Dr. Fish. That was an amazing presentation. And, I think one really important thing to note about your presentation is many people associate innovation with, a specific idea or an end product like technology or a digital app. But I think what you presented is a really great example of how you can look at innovative ways to really transform whole systems to advance health equity. And the most really innovative solutions come together when you bring a whole diverse group of leaders and stakeholders to really be that voice for the community. So I think we'll move on to questions. We have a couple questions in the chat here. The first, can you, Dr. Fish, share how is the coalition being funded initially, and what are some plans to make it more sustainable?
Great question, and I'm chuckling a little bit because just yesterday, around this time, was in one of our not frequent enough meetings in person of the Health Equity Compact. We've done Zoom sessions and the like, but getting in person is really, really so important because we're humans. We need that, and so. At the end of the session, both Michael Curry and Manny Lopes made the observation and point that all of this work ain't free, and so they are going to be asking the Health Equity Compact members again, which are 67 different institutions in Massachusetts, to it's always talent, time, and treasure, and to respectfully give of the treasure aspect. So we are all self-funding right now. We do believe that there is alignment with several of the larger, more moneyed institutions to put together grants and that grant opportunities for us to respond to and to pull down some grant money as well. So that is in process. But I think, like many things, you can raise money in what I call alms for the poor mode, right? Give because it's the right thing to do and poor us. Or you can ask people to join a movement that we all know is the right thing to do and is making great strides. That's what we're doing.
Wonderful. And someone else asked, what success have you had in addressing the workforce issue?
That was actually the whole point of the session yesterday, was to dig deep on workforce. And so we haven't cracked that nut yet. I don't think anybody has, but we've begun to really pull apart in sort of the journey from thinking about employment to, already got the job. How do I stay in the healthcare system and not get drummed out, particularly if you're a person of color, meeting, racism challenges in the healthcare ecosystem. All along that process, from getting training started, being supported during training, so your childcare needs are not pulling you in the wrong direction to stop training, and on and on. Early mentorship and career mentorship. We're looking at and examining all of those pieces, and so we don't have the answer yet, but we're systematically working through that.
Great. And just a reminder, if you want to ask a question, please go ahead and pop that into the Q&A. You talked a little bit about this in your presentation, but looking and talking about terminology. So first, talking about social determinants of health, you talked about that transition to social drivers to health. Can you talk a little bit about that? About the progression of that terminology, and just kind of shed that light for everybody on the call. There were some questions around that.
Yeah, so I've adopted changes to both those terms. I've changed from social to societal because, social sounds like, hey, let's go to the bowling alley and hang out, and societal says, no, we live in a society that has certain rules, spoken and unspoken. And so let's be intentional about that, calling out how our society plays a role in people's health care and health outcomes. And then determinant sounds literally deterministic. If you live in the zip code, you are fated to have this. But taking the foot off the gas a little bit to say it's a driver, and we have choices in which drivers we're applying or not applying. It's not deterministic, right? So I can't write off everybody who lives in the 02116 zip code or something like that.
Thank you. Let's see, a couple more questions. Any recommendations for a federally qualified health center looking to start screening for SDOH later this year? How can we make sure we're properly addressing needs?
That's a great question. When I landed here at Greater Lawrence Family Health Center 2 years ago, the organization had crafted its own screener, which some things you just have to live with. They also elected to go with a specific EMR solution, which it's like, okay, I wish otherwise, but be that as it may, the important thing is to get started with the screener. The one that I was advocating when I landed here, but backed off of, is one called Prepare. And I think the National Association of Community Health Centers advocates and has links in its sites to being able to access that screener tool. I'm thinking in the direction that as long as we are all asking the same questions and collecting the data so we can compare from Massachusetts to Missouri, from Alaska to Alabama, we're asking the same questions about what's happening. What is the experience of food insecurity and homelessness, et cetera? That's when we're really well off, having robust, shareable, analyzable data. It's when we're all measuring something different or don't have a complete set that we've done ourselves no service. So, but I would look at Prepare.
I think, let's see. As part of your work, are you partnering with any academic institutions to provide clinical experiences for students enrolled in schools of nursing, medicine, or social work to have them address SDOH in health centers?
We haven't gotten there yet with the Health Equity Compact. I will say at my institution, Greater Lawrence Family Health Center, we started the first non-academic medical center residency program for family medicine in the world. We are now up to a 4-year program with 10 to 12 students per year. We do have areas of concentration. Some people choose to concentrate on OBGYN or prenatal care. Some are looking at the whole area of societal drivers of health. And part of that curriculum is getting them out into the community, finding our community partners identifying with them things that they need to or want to improve, and developing research and interventions along those lines. So that's kind of what we've been doing here. I think it's going great. I know there is a push to fund other teaching health centers with support from the federal government, and I would fully endorse other health centers doing the same.
We have lots of questions coming in. So thank you all to adding your questions. I'm just going to keep throwing them at you. What advice would you offer to health equity champions across the country looking to get started in statewide efforts? How about consideration for people in areas that are more restrictive?
Mm-hmm. Right. So I do sit in a very deeply blue state. And so we do have an experience here that may not be readily transferable everywhere. But, health and health equity are, health is everywhere, and health equity is a concept that I think is destined to be seen ubiquitously as a people issue, not a red or blue issue. We're also very privileged, as I mentioned, to have Jeffrey Sanchez here, who knew so very much about the legislative process. And my suggestion would be to look in your state legislatures for people who are identifiably, interested in and concerned about health equity, and discuss with them what's going on in Massachusetts. Call us up. Get a hold of the Health Equity Compact, and start there. The art of the possible, right? Start with the art of the possible in your area or your region, and build on that. We swung for the fences here because we've got a track record of, like I said, Obamacare or Romney Care and other things. But you may need to right size it to the ecosystem that you're in. Start small and build from there. But really finding people like Jeff Sanchez, who's been in the state legislature, knows the ins and outs of how to get things moved along, where to drum up support, and then the other part of the magic was that we were able to staff it with the staffers from the Massachusetts League of Community Health Centers, who were commissioned, I might say, by their CEO to advance this work, quote, in their spare time. Wasn't their spare time; they're being paid for it, but that was certainly helpful as well.
Yeah, that's a great question. And kind of along those same lines, that how do you convince powers that be of the importance of diversity in addressing the healthcare professional shortage? Yeah.
So I think I'm going to ask a little bit of patience for a few months until the Altarum report comes out, which I think will speak to that either directly or indirectly. The other thing is that, there is just a rash of literature out there in academic journals already that talk about the differences in outcomes when individuals receiving care identify with the provider of care because they're from the same racial or ethnic background, speak the same language, same, SOGI orientation. So that data is out there already. I know that we have a problem in this country with, people standing up data on one side and emotion on the other. But if we can agree to the same value that we want, we can't afford as a society for people to not get the care they need and end up costing more, right? And so therefore we have to back it up and make sure people get the care that they need. And the best outcomes come with this data, right? Showing that having alignment in some respect between provider and patient is super important. I think that's how you get there. Start with the values, shared values, and then back into the data.
And yeah, I think we have time for about one more question along the lines of data. So, you're talking a lot about the data and its importance. You talked a bit about using Prepare, But, community health centers continue to experience a lot of challenges in collecting and analyzing SDOH data. Do you have any more recommendations, innovations, or strategies to address this?
I would say my friends and colleagues from the IT world say this all the time, right? That being able to collect and analyze more data gives you better answers. So as an individual health center, I need to do what I need to do to make sure that in my population, I'm not ignoring and am addressing particular pockets of patients. But if I can combine my data with 3 other health centers, 10 other health centers, 30 other health centers, but also my resources so that we can get, better analysts working on the data with better tools, I think you get a lot of traction that way. So my recommendation would be to call up your other health centers in the area, in the region, and see if you can band together with creating a data consortium and doing data analytics on bundled data.
Thank you. I think I speak for everyone to just say thank you so much for coming today and sharing your expertise around this. I think it was incredibly insightful and inspiring. And you could just kind of source through the comments that everybody really has taken what you have spoken about. And hopefully that sparks innovative, creative solutions in their communities and in their health centers. So again, thank you. Thank you very much for coming today.
Thank you. Thank you for having me.
Yeah, of course. Just to wrap up, let's continue the celebration. So as I said in the beginning, this is the first of 2 webinar series. The next session will be next Tuesday, April 18th at 2 p.m. Eastern Time. We have really exciting agenda where we'll engage a panel of experts in the field of what exactly innovation means and how to address barriers to implementing innovative programs focused on SDOH and the future of this work. You can see here our panelists, and please register on the link below. And I think someone can pop that into the chat as well. Next slide. Also, we have collectively as faculty, we have a number of resources for health centers that you can find on things that we talked about today, but also about SDOH in general. You can visit the Health Center Resource Clearinghouse and for more information. And a couple of people asked this in the chat as well, but we will be sharing the recording and the slides at the end of the week. Please take a moment to complete the evaluation for today's webinar. It shouldn't take too long. Someone just popped it into the chat. Thank you so much. If you could just fill that out, that could really help us in just hearing from you on how to provide information on what y'all's needs are and improve for the next session. Next slide. And again, thank you so much. The evaluation is in the chat, but I just, again, want to reiterate, thank you for coming. We hope you enjoyed today's session, and we will see you all next Tuesday, April 18th. Have a great rest of your day and rest of your week, everyone.